Awesome.
Sure. All right, y'all. So thank you for having me today. I'm Bree Garbus. I'm a clinical assistant professor within the College of Medicine School of PA Studies. So I work at the EAC primarily in Bartley Temple, although I also cover the Anthem Clinic and then Women's Night at Main Street. So three clinics, so background in OBGYN and family medicine. And then my role in the School of Physician Assistant Studies is a whole bunch of teaching variety of classes, our women's health, GI, pulmonology, physical diagnosis, radiology, clinical procedures, advanced clinical practicum, and then I also teach the evidence-based medicine and master's capstone project, which is the research component of the physician assistant program. So I have a handful of publications out there and then one pending acceptance. So that's a little bit about me. Is there anything in particular you are looking for?
No, that's awesome. We're glad to have you.
This is a
And
little.
yeah, for the audience here, feel free to jump in with any question you have throughout the
Yeah,
workshop.
sure.
And in this workshop, we'll cover the PRISMA checklist and in
Mhm.
particular the method and result section, as well as address specific question we have as well.
Sure, sure. Okay, so the kind of the quick rundown on the PRISMA 2020 checklist. Your paper is going to be a specific review of the project that we are going for is looking at contraception options and overcoming barriers to contraception in our particular clinic system, which is our medically underserved population that we work with within the greater Alachua County area. So we still had a couple of questions that we were looking at from the last time we met. So some of that will play into some of the questions that were asked of me in this Google Doc. So title easy. In the title, you need to report as whether a systematic review or kind of the neat thing with PRISMA is you can decide to do a systematic review and a meta-analysis within the same paper. Making that decision, a systematic review and or a meta-analysis will determine some of the steps and methods and results because meta-analysis will have a bigger component of statistics. The abstracts, there's its own separate checklist for abstracts. So abstracts is something that you can actually usually write abstracts at the end of a paper, not at the beginning, which is going to sound kind of weird, but that's when we tend to do it. So then when we get into introduction, it's why you're doing it, and objectives, what you're particularly looking at answering. Now, in methods, so eligibility criteria, the first thing that we are doing is what particularly you were looking for when you did these reviews, when you did your systematic review, what did you use as your inclusion and exclusion criteria? So it's important that we have narrowed down our topics, exactly what we were going to do. And this, our study was a little broad the last time that we met and talked about it. So I don't know if we've narrowed that topic down or not yet, but one of the big things is that we have to have narrowed down what we are looking for before we can really continue on with what we are going to be doing in this study. So it's important to know what we are looking for. So when you think about the PICO questions, are you all familiar with PICO format? Population being studied, patient population or problem being studied, the intervention being studied, comparator, and then the outcome. So comparator is always an option, but we have to have population. So we could say be looking at patients seeking contraception is a population. Patients who had unintended pregnancies and out as in patients with unintended pregnancy, that would be considered a problem. In all patients who came to the equal access clinic, that's a population. The intervention then is people who were provided contraceptive care or who were not provided contraceptive care. And then we have to decide on the outcome that we want. So that will be able to help us decide the inclusion and the exclusion criteria that we're going to give on our study. When we're talking about that element, so the population is going to say something like, we included we're going to decide that we wanted to use all randomized control trials, or we wanted to use all case control trials, because we decide on the type of study that we use depending on the population. We're looking at all adult patients. We're looking at populations that are 16 and older or 15 and older, because in Florida, there's a certain age limit at which patients can obtain contraceptive care on their own. They don't require an adult. So we are looking at all randomized controlled trials of this particular age, patients who were seeking contraceptive care and who were able to come to the clinic. The intervention that we considered was patients who were given prescriptions of oral contraceptive, IUD, Depo-Provera injection, and you include all of the interventions that you are looking at that particular time. Examples that we did not include were patients that were referred for sterilization, patients that already had hysterectomy. So a patient that was given a hormonal intervention for a reason that was not related to the contraceptive that you were looking for. Outcomes to be included: a study must have had a defined clinical outcome relating to the complication that we were looking for. So unintended pregnancy. And we have to sit down and define exactly what outcome that we are looking at. Another barrier. So an educational barrier, an access to care barrier. So what outcomes are we looking for? So in item 5, we are going to specify our population, our intervention, and the outcomes. We may include a comparator in there, and the intervention can have only one comparator. So we have to think about what comparator we may want to use. And then we talk about the grouping for synthesis. In 7, when we're talking about, I skipped 6, yes. So we're going to talk about all databases that we are going to use. So we're going to talk about a date and when we are going to use that date. 6 is always a big old giant table. So we may have a little paragraph that goes with this table, and this may have a date range. So we can give an example that on or during the dates of June 15th to June 21st, the research team searched the following databases, and you give a number. So you may have searched 20 databases. You may have searched 15. We searched the following X number of databases to include those listed in table. And usually this is going to be your first table. So table 1, we carried out you may use an avalanche search method. You may use a snowball search method. You may use a generalized search. We use the reference list of publications. You could use full text review. You may use an abstract search. We looked at all inclusion criteria from all inclusion and exclusion criteria for our review previously listed. You may see Appendix 1 for full details of our supplementary search. And in Appendix 1, you're going to list all of your search terms that you used, all of your mesh criteria. So Table 1 is going to list the database that you used. So let's say we started with PubMed, and I think that is on question 1 was, what data extraction strategies do you recommend? If you go into the UF Health Science Libraries databases, there's CINAHL, there's PubMed, there's Ovid, Medline, EBSCOhost. Those are probably some really great ones to start with. In those, and I wrote my answers out for you, so I can put those in the Google Docs, so you will have all of those. Those are some great strategies to start with, but you're going to not only list the database, but then you're going to list the time period in which you search that database. So let's say you looked back, you've decided to look at recent studies within 10 years or 5 years, the time period in which you search that database. Okay.
Sounds good.
In 7, you're going to end up listing the full search strategy. And the full search strategy gets to be like almost a little overwhelming, you are going to talk about all limits. So you're going to list every single search term you used, whether you listed it by, let's say you used unintended pregnancy, female, low socioeconomic status, free clinic, student clinic, Florida, economic pattern. Like, this is a very, very big, somewhat overwhelming table. It could have easily 50 to 100 terms in it. So this is something that you usually do in a supplementary table. So you talk about, you'll give one example that you say, you'll give one small version that you give the full search strategy in, and then you, for one search, and then you will say, see supplementary table 1A for remaining strategies on Ovid. You may give CINAHL's full search strategies, and then you will say, see supplementary tables for remaining. So those will be in the appendices and not listed in the presenting paper.
Would this be one of the flow diagram, or?
No, the flow diagrams are separate. The flow diagrams are a summary. So they'll say, like, you will look, articles reviewed, N equals 78. Mm-hmm. But the search that you did was how many terms? How many terms did you put in to keep narrowing down? Does that make sense?
Yes.
Okay. All right. So when we get into 8, in 8, what you're talking about is how many people, what were you looking at in 8, and how was it done that kept things kind of on the up and up? What was your selection criteria? So in 8, how did you decide that the articles that you pulled from this search strategy was reasonable? Should it have been included? So you decided your inclusion criteria, you ran the database, now you've got all these articles. How did you decide that article should be included or not? So multiple reviewers, multiple of y'all should review each study and decide, yes, it met our inclusion criteria. So we decided that our P, I, C, and O, did this study meet our inclusion criteria? Are we only going to go with large randomized control trials that are in the Southeast because there are different prescribing materials and prescribing practices throughout the United States? Are we only going to use case control studies or cohort studies or qualitative studies? What are we going to go with? Did this meet our trial? So you are going to decide how many reviewers reviewed it and whether you guys worked as an individual group. So your process may be, and this is something you have to decide ahead of time, your process may be that each one of you is going to review 50 articles, and then you're going to make those decisions, and then you're going to convene as a group and say, all right, I chose these 25 for inclusion. And then you'll review that. Did all of you choose the same 25? And if you automatically did, then they're all going to, those 25 are going to get in. And if an article didn't make the full selection process, you're going to debate over that. And you have to have at least a 50% agreement for it to go in. If an article wasn't chosen by everyone, then it's automatically out. So you have to decide that process ahead of time, and then you're going to explain it. So you'll write a paragraph or more that says 6 researchers or 5 or 4, however many that's a majority of your group, and initialize or numbered 1, 2, 3, A, 7, 4, however you decide, have independently reviewed or met as a group multiple times throughout a 6-month period, reviewed titles, abstracts, and or full reports, and discussed inconsistencies, or met individually, selected articles, and then met as a group, met in pairs, only met as a group, reviewed articles that met selection criteria. In the case of disagreement, consensus on articles was decided by. So you're going to talk about how you chose the articles, and then as a group, how you made your final decisions. how you made that final process. And then you are going to clearly outline what you did to make your decisions. Does that make sense? Okay, I see that question, Mia. I will grab it here in a minute. And I don't think there's not a question on that one yet. In 9, we're going to talk about specifying the methods used to collect data, including how many reviewers reviewed data from each report, whether they worked independently. And it's going to sound a whole lot like 8. So it's very similar to what we just did in 8, except in 8, we chose the reports. 9, now we're going to say, all right, so we just chose those reports. Now, how many people actually looked at the data from each report? So this is a very similar process. How many people now not only chose the report, but went through the entire thing, went through the data and decided if the data was actually reasonable and good, if the data had errors, if the data had problems or not. So you're going to do the exact same thing. You're going to do what's considered like a data extraction form. So this is very similar to the Google Doc that you guys created for questions. Now you're going to say, we designed a data extraction form using, you could use Excel spreadsheet, you could use an SPSS or a mini tab, you could use you could just even use a plain Google Doc or a plain Google form, and had 2 or 3 or 6 review authors, and use it to extract data from eligible studies. Now, not all of your studies are going to necessarily have eligible data, right? Some things are purely qualitative and don't have hardcore data, p-values or confidence intervalues. You're going to pull comparable data from those studies. And then if there are massive discrepancies between data, then that you have to resolve with some sort of data software. So that's where the details of automation tools are going to be used. So I highly, highly, highly recommend a statistician. I use a statistician for anything that's more complicated than like a regression analysis or running confidence values or p-values. I can grab those out of Excel pretty easily. But if I start getting into running, 30, 40 studies, I'm going to use the College of Medicine statistician because I am not a statistician. I am not one by trade. I am definitely not one by nature, and I do not like math. So I will use someone that is their degree. That is what they were trained to do. That is what they do every single day. So when we start talking about, most of the time I know what test to use, but I don't necessarily know how to put the data in there to do it. So I will use someone who is very good at that. So when we need to get someone to do the stats, that is what we are going to do. In 10, we need to figure out the outcomes for what the data was sought. And that is where there was a question on here. Unsure how to approach 10A. So 10 has a lot of sections. It's like 10A, 10B. We get into 10C. Come back here. 10 has a lot of pieces. 10A, 10B, and that's it. 10A and 10B. Okay. So 10A, we're looking at the outcomes for which the data were sought. So this is one of the things where we have to have decided what outcomes we are looking at. So for an example, and you need a time frame too, you might be looking at an outcome of unintended pregnancy within 1 year of a visit to a free health clinic or a medically underserved clinic. That's an outcome. You could be looking at something like a patient having a heart attack, an MI, within 6 months of seeing their primary care doctor for hypertension. So you could be looking at a patient's pain score. You could be looking at a patient's quality of life score. You could be looking at a patient's anxiety rating following a trip to the dentist. So you are looking at an outcome of your decision, and you could have multiple outcomes. I might be looking at quality of life, pain, anxiety, and depression, all following one visit to my office for any complaint. I could be looking at multiple outcomes, but I'm looking at that within a particular time frame, right? I need to specify a time frame. You get to specify both the outcome and the time frame. I'm looking at 6 months. Now, if you're looking at something like an unintended pregnancy, you might want to range out the time frame a bit, because unintended pregnancy has both, takes a little bit to get pregnant, and then the effects of an unintended pregnancy can, you stay pregnant ideally for about 40 weeks. So you might want to give that like a year time frame. If you were looking at economic effects, you want to give that a little bit longer too. So you set your outcomes, and then you set your time frame that you're interested in.
So this ties back to the eligibility criteria, what you include.
This is going to be tied back to your eligibility criteria. Yes, you need outcomes. So think back to our inclusion exclusion criteria, PICO. O is outcomes. So this is that outcomes for which data were sought. Did we find results that were in the outcome of the domain? That makes sense? So that a lot of these things start tying together, which is really good, because this is a pretty decent size way to do a review. It's extremely well put together, but it is really, really big too. So we want to have things that are put together. So we're looking at all the outcomes. And then in 10B, we're looking at other variables that we found out or that were sought. So maybe we're looking at characteristics of the study. So we're looking at unintended pregnancy within 1 year of a visit to medically underserved clinic. And we find out some other interesting variables like participant characteristics. All the patients within 1 year of a visit to this medically underserved clinic were all individuals of a particular ethnic group, or they were all individuals of a particular socioeconomic group. All patients came within a certain time period at night. You find out other outcomes, things that you didn't plan on studying. They weren't your planned outcome, but hey, there sure are all there. And then you also are going to note the characteristics of the study design. Were they randomized? Were they not randomized? Were they all female? Were they all male patients? Were they, if you're looking at pregnancy, you probably are looking at patients who were assigned a uterus at birth, but not always, right? So there are things that you are going in 10B, we're finding out other variables that were not necessarily the outcome that you were looking at in the first place. Okay.
So starting from 10 and onward, it's kind of like you assess those items for each article you end up including in literature review.
Starting to, yes. Now, some stuff you can assess as a group, and some things you are starting to assess individually. Okay. 11 is a risk of bias in the studies. And when we're in 11, where's my 11? In 11 is across the bias, across the board in all studies. So instead of doing individual studies, you're looking at kind of an across the board grouping. So you are looking at, you can use robust. This was question 4. Somebody asked, is risk of bias solely subjective? It's highly subjective. There are some very strong things you can look at. And you actually can get what's called, so Grade has a Grade software, and you can get a free institutional account with Grade. You can go in and sign up for it, and then you can put your writing in, and it will help you determine whether it's the best objective subjective you can get. So I highly recommend signing up for that. It will help you be less subjective about your bias determination. So there's also so Robust uses the revised Cochrane scale. And when you write up 11, it's going to talk about helping you assess bias by looking at randomization. So you look at all your studies and determine the studies you used, were they randomized? Were they all randomized, or were some of them randomized using, so the best method of randomization is always computer-based randomization. The computer randomizes, that's wonderful. The computer is unbiased. The computer does not take into account, this patient, they have a really sad story and I should put them in, or oh, I know this patient and they would really benefit from this trial. I should put them in the experimental drug. The computer doesn't care. Computer does not know that. The computer just knows that this is patient 277 and patient 277 is selected for this group. That's all the computer cares about. So computer randomization is the way to go. So it's going to look at randomization process, and then it's going to look at, was the protocol followed? So if the protocol is deviated, why is the protocol deviated? Why do we deviate from protocol? We deviate from protocol because things aren't going the way we want them to, right? Either a patient is maybe not having an outcome we want them to, like halfway through my study, I noticed my drug is working so well, and I want my drug to work really well. And I noticed that, this drug is doing great things, and this patient over here, and they're suffering, and they would probably do really well so I put them into that trial, I switch them, or it's not going so well and I know that something's wrong, so I make an adjustment to my protocol. So randomization, deviations are bad. I mess up on my data problems, always a bad thing. And then bias in result reporting. So we call that publication bias. We will see publication bias because nobody wants to print results that make a company or a university or something look bad. So if the results are kind of skewed in favor of something, then so Cochrane will help, that nice little method will help you find bias. So usually a couple of reviewers need to be looking across the board for that and say, well, this article reported non-randomization. This article reported 3 protocol deviations. This article reports some data that went missing. This article reports a change in protocol at the very end. So you can put that through your Cochrane analysis or through your GradePro software, and it will tell you where that the bias skews on this, or that there's very low risk of bias. So then you'll report, we assessed risk of bias using Robus. We assessed risk of bias using GradePro. With 2 separate reviewers assessing risk of bias, we found that minimal judgment of bias was found throughout our article protocol, or 2 separate reviewers found high risk of bias across all studies in this protocol. Any discrepancies were resolved. So one person found high risk of bias, one person found low risk of bias by bringing in a 3rd reviewer. So you want to talk about how you assess for bias, what your resolution protocol was, and then if you had a study that had extremely high bias, what you did about that. Did you keep the study, or did you say, very high bias study, we kicked it out? We found that this study was the highest bias of all of our studies. Due to that, we removed it from our review. Does that make sense? Because studies with very, very high bias probably aren't the best study for you to keep, right?
Right.
Okay. And I think that answers 11. Yes. And then we're going to get into the question that was under 4 about statistical numbers in a minute. And then we're going to get into 12 down here next. So 12 and 13 had a lot of questions on this paper. 12 was specify for each outcome the effect measure, such as risk ratio, mean difference, using the synthesis or presentation of results. So what we're getting into here is, how are we going to take all these articles that all say something and try to bring them into, we're starting to try to bring them into a conclusion of results of some particular way. There is pretty much no way on the planet that they all use the same statistical analysis. It would be super cool if they did. And if you managed to find that you probably introduced bias by only finding articles that had the same statistical analysis, or you're the luckiest person on the planet, and I would like to go play the lottery with you. So what we're trying to do, you need to report what effect measures that were used across the board. You want to say what was used. So perhaps your articles, handful of them used what's called like a risk ratio or an odds ratio, or they used standard deviations on half of the articles. You're going to need a statistician here, because what you will end up needing to do is decide what the majority of the articles used for how they reported the effect. So if we were using, say, a treatment, we might say the risk ratio for this medication. Or if we were using a survey, we might say that the mean difference between this provider and this provider was 2%. We will end up, again, consulting a stats person to convert pretty much all of that data into one major piece of statistics across the board. So it would say something like, what we plan to do was an analysis of outcomes using a risk ratio or a mean difference. We can pick one statistical analysis. Many different measurements were used throughout our studies. In order to assess similarity, we used a standardized measurement of whatever one we've decided to go with, 95% confidence intervals and standard deviation, and then report that. So that's going to be a big old calculation. And unless somebody's a statistician, and if you are, I love you very much. If you're not, we're going to find a statistician. So CTSI is pretty good for that on UF campus. Each student gets like 2 free hours, I want to say, and there's a whole bunch of you. So I would recommend you all don't go as a group. I would break that sucker up into 2 hours per student. Good plans. And then we get into 4A question up there. How do we obtain the statistical number to be included in your method quality assessment? So that's where we're starting to get into 13. And 13, as you can see, breaks down into A, B, C, D, E, and F, which is crazy. 13 is huge. So we're talking about in 13A, we start out with the processes used to decide which studies were eligible for each synthesis, tabulating the study intervention characteristics. And this is not terrible. It looks terrible when it starts off. It's going to be like, are you crazy? This is so much stuff. But the big thing here is we're going to take all of these studies that you have, and we need to what's considered codifying them. So not every single article chosen for your review is going to have data. Some of them will have data. Some of them are going to be like guideline reviews. Some of them are going to be more qualitative. You're going to decide the criteria for which you are going to want to include articles for the meta-analysis. You may not have any that are going to be meta-analysis worthy. So you may not end up having to do a major synthesis of data. You probably will, but you may not have to. So we want to try to keep things that are coded together. So similar population, similar study size, all done like the same kind of environment, like a low socioeconomic status. So you will make a decision as to how you want to code your articles together for a synthesis. And then you have to describe which studies were eligible for each type of synthesis. You could potentially have 2 or 3 sets of synthesis in one systematic review. So if you have a handful of studies that looked at, let's say, I'm going to just kind of keep picking the unintended pregnancy one because it's kind of an easy thing to exemplify. So let's say you looked at unintended pregnancy in that time frame, but you might look at like inner city population versus a more rural population. You might look at migrant workers specifically. You might look at a transgendered population. So each group is its own code, right?
Mm-hmm. Does each grouping affect the subsection of discussion?
Yes, each grouping sets. So that's a different population, right? Different population. So it's a different subsection of the discussion.
Mm-hmm.
Yep. So then you're going to talk in 13B, we get into describing the methods to prepare that data. So did you have to convert your statistics over? Because within that small group of data, they probably didn't all use the same statistical methods. So did you have to do your conversion from odds ratio over to a risk? Did you have to convert means? Did you have to use standard deviation conversion? What did you have to do to make it match? And then did you decide to put them all into like a table? Did you do something like that? So like a an example for 13A, and this is why you'll really like this paper that I sent you, because it gives beautiful laid out examples. It said, given the complexity of the interventions being investigated, we categorized included interventions in 4 dimensions. Was housing provided? So this particular study looked at housing effect on patients getting health care. So they broke it down into whether housing was provided, to what degree the tenant's residence in the housing provided on their being sober or attending treatment, whether the housing was provided as part of like a big group housing segment, or whether it was case management based, whether they got put in like an individual house and managed by someone, or whether they received a voucher and could choose their own housing within a particular region. So you could see how each one of those houses, how each one of those situations was codified, right? Because that's different groups of people, different studies. So in B, then they talked about they had to use cluster adjusted estimates because they had randomized controlled trials, but the studies didn't adjust for clustering across all the different ones they looked at. So they had to adjust standard errors. So they had to do some statistical adjustments in that. Then in 13C, what you end up having to do is describe the methods that they use to tabulate. So, and then in 13D, you are looking at methods using to synthesize the data and provide a rationale for the choice. So 13D starts getting into our, what are we going to use for choosing your meta-analysis. So this gets to be kind of a bigger effect. Are you going to use what we call fixed effect or random effects? So fixed effects and random effects. So the synthesis strategies. This is where you have to really look at your studies. And especially when you're using very large studies, fixed effects model is what's going to assume that all studies estimate the same common effect. So that when we're looking at this housing effect on alcohol and medical treatment, assumes that the problem with homelessness is alcoholism. It's a huge player, right? If you have alcoholism, you have a much higher likelihood of eventually ending up homeless. Job instability, family crisis, lots of problems. So if you are an alcoholic, long-term alcoholic, you have an increased rate of homelessness. This is a known fact. But it's not the only fact, and it may not be the primary fact. So the random effects model says that there could be variable factors influencing alcoholism's impact on homelessness. So when you do a large study, you are most likely better off using what's called the random effects model than the fixed effects model. So that is a statistical thing. That's a statistical analysis. So you choose whether you want to run the fixed effects model that says my problem likely is the common denominator, or the random effects model, which says my problem could be the common denominator, but it could be multiple other things playing a role. So as a general rule, I'll run the random, or I'll have the statistician run the random effects model over the fixed effects model if I have more than 35 to 40 studies. If it's less than that, then we'll run the fixed effects model because it's likely not going to be as many. The common denominator will likely be less in a small amount of studies than it will be in a large amount of studies. So statistician for sure when you get into running the meta-analysis on a fixed or a random effects model.
So to clarify, the fixed or random method will be used for each code, so each grouping that you...
Yes, is used. So used for the grouping. So then when you get into subgroup analysis, you're only going to be on 13E, you're only going to be doing subgroup analysis if you have multiple groupings. You may be able to do it in one. It really just depends on how many groupings you end up with. Sensitivity analysis also going to depend on how many studies, on how many groupings you end up with. You may have several, you may have one. 14 methods used to report biases. On 14, risk bias, this is individual studies. So you are looking at biases in individual studies on this one. This is appraisal of each study. You want to do this in a table. Is it randomized properly? Is it blinded? And when you do that, where's my 14? Come up here. Is that right? Yep. Any methods used to risk of studies and arising from reporting biases. So when you're doing 14, you are looking at, did this study have you can also do like a funnel plot if you wanted to. That's something that stats can make for you. So funnel plots are particularly helpful about showing the funnel plot comes down like a tornado, comes down like this, a good funnel plot. But if it spins off to the side, then the data was unevenly distributed, and it will tell you if there's bias in the funnel plot. Usually it won't tell you where it was, but that will help you determine whether there was bias of some sort. So you can talk there about, again, whether you used Robus or whether you used GradePro, and then whether you entered it into a funnel plot or not. So sorry, that's not where you put the table. That's where you want to talk about using a funnel plot. Certainty assessment in 15. This is where you are going to talk about what criteria you are using to say for each important outcome that you've given. So for each of your outcomes, whether you are talking about quality of life, patients' pain assessment, lowered blood pressure measures, improved mortality rates, for each important confident measure that you have, how certain are you that what you have found in your body of evidence, how certain are you that what you found is accurate to what you have said? So that is getting a little bit harder to prove, right? So now you're again going to go back to say which researchers. So 5 people, B, G, CS, MK, have reviewed the certainty of evidence. We used usually grade, because grade is going to give you bias and study limitations, and whether or not the study was precise, to assess the evidence. And we have decided that it was high, moderate, low. Again, that's where grade is going to be really, really helpful, because when you've put in each study, it will go through and help you calculate those things. We considered whether the study had a large effect, whether the study had any confounders. So confounders are like outside things that could happen on the study. So let's say that we were looking at the effect of blood pressure being treated by a student-run free clinic. And I produce a study that says patients coming to a free clinic have greatly improved treatment of hypertension after 6 months. But in my study, you find that I had 50 patients that I followed for 6 months. But I only put patients in there that only had hypertension. I excluded all patients with diabetes and heart disease. I did not take any patient that had a BMI of over 26. I didn't take any smokers. Is that a good study? It's a crap study. I took patients with 0 risk factors, right? So as long as they came to my clinic and got their medication, they were going to do better. Conversely, if I took, so the confounding factor there is researcher, right? I was very specific on my exclusatory criteria versus if we did a study that said that I had 100 patients that came to the free clinic and they got their medication, but all of them had little to no improvement in their blood pressure. And it was during the time of February 2020 to August 2020. What would the confounding factor be? COVID. Yeah, exactly. There's a huge confounder there, especially in the free clinic population. The clinics were closed. Patients could call in for telehealth, but I'm relying on the 40% of my population that doesn't have internet and very spotty phone service to get to a telehealth appointment, which a whole bunch of my patients, yeah, right, they can't do telehealth. They don't have the access. They just didn't have the access. So confounding factors are things that happen that are usually outside of the subject's control, and the researcher usually does know about, but they're serious confounding factors. So almost all of the COVID studies that are happening or have happened have massive confounding factors. People are doing a lot of research on the effects of COVID on depression and anxiety. So there are some big confounding factors there, like patients that had social phobias. COVID may have helped them a lot because suddenly it became the norm to not leave your house. In fact, it was recommended. So for those patients, how did they feel during COVID? A lot of them, they reported feeling better because now it's not socially unacceptable to not leave your house. So people aren't like, well, why aren't you leaving your house? You should come out. Why aren't you coming out? It was like, oh, hey, let's all stay in. So the social phobia people reported feeling much better during COVID for a large majority of the patients. And those studies reported feeling better. Were there medications for social anxiety helping?
Don't know.
I have no idea. There's too many confounding factors. The world stayed home. Everybody stayed home. We have no idea if their medication prescribed. So the trials for social anxiety during COVID basically got killed because we have no idea if the medications or cognitive behavioral therapy for this social anxiety symptoms got better or worse because the patients were staying home, which in essence is what they felt like doing. So they got better, but we don't know if it was the therapy or the action that made them better. So confounding factors, both the researcher and the patient are aware of them, but there's really not a lot you can do about them. Confounders, so things you have to talk about in your studies. All right, where certainty assessment. So you have to talk about those things and how you rated the certainty of the evidence, how many people rated the certainty of the evidence, what you decided on, and if there's ever a disagreement between the researchers, and there will be. So what you don't want to have in every area where you have to assess is we both agreed and it was, immediately, because nowhere in the real world does that happen. So you justified your decisions to up or downgrade your certainty, and then what you've decided on moving forward. All right, so moving into results. In 16A, we are going to, let me get back to find my 16A. All right, we are going to describe the results of the search and selection process. So this is where we are going to use one of the flow diagrams. So I sent you guys all the flow diagrams. There are 4 flow diagrams. You will pick the one that applies to you. So some of them are using different forms of literature. So you pick the flow diagram that applies to you, basically fill in the blanks. So it's super handy. And all of them are, you fill in the ends. How many studies did you use? And you will insert that flow diagram into 16A. So that's the the results of the search and selection progress. How many records did you start with? How many records did you get down with? And that is what you're going to use. So 16A is a flow diagram, which is excellent.
There's a question about if we use the older version of the PRISMA flow diagram, do you have to convert that into a newer version?
You need to use the 2020 version. Yep. So you do need to use the conversion. Absolutely. Yes. Great question. Yep. Yep. So you're going to bump over to the new diagram. And then 16B, you do want to put in the studies that almost met or appeared to have met, but didn't, and talk about why. Why did you decide to kick that study out? And you can do that in, so your 16A, underneath your flow chart, you're going to have a very small paragraph that's going to say, we found a total of 3,000 studies searched. We removed 500 duplicates. We screened 2,500 records. We finally reviewed 50 full text documents and decided to include 25 papers. Each were cited. We then searched X number of documents that cited any of the initially included studies and the references. However, we found no extra additional articles that fulfilled the inclusion criteria. Please see flow diagram above. And then in 16B, we excluded 7 or 10 or 11 studies from our review, and we listed reasons for exclusion in the characteristics of the excluded studies table. We excluded these studies because, and you're going to talk about why they excluded them. They almost met criteria. However, they talk about free clinics that do not provide any contraceptive services due to religious reasons, due to they see biologically male patients only, and would therefore not have the option to provide contraceptive services. However, you look at what you want to, why you're excluding them. Mm-hmm. Now, when we get into 17, this is your best opportunity for a very straightforward table. Okay, so in 17, this was question 5. Do we need to mention all articles included in the review? Yes, you are going to do that, but you're going to do that in a very nice chunk table. So your table 2, 3, 4, whatever we're up to now, is going to say the table displays for each study included the citation, design, and when you do citation, you're going to do author and year. The study design, the population, sample size, like the mean age, the breakdown of so whether it was adult, pediatric, male, female, both, and then the follow-up time frame, if that's applicable to you. So basically, you're just giving a bird's eye view of your study. And then the identification. So was this a self-reported study? Was it followed in an office setting, followed in a hospital setting? This was a clinic study. And then was it something that patients were dosed with medication? Was it something that it was a survey study? And then outcomes. So what was the primary outcome of the study? So was this, so remember what outcome are you looking at, right? Are you looking at a quality of life study? Are you looking at lowered blood pressure? Are you looking at unintended pregnancy? Are you looking at job loss? What are you looking at as your outcome? So outcomes should be in there. So it's one table, and it can be a pretty big table, but you must have that in there. Okay.
Yes.
All right. So that is in there, all studies.
I guess one question on that, when you're writing the discussion session, do you have to reference the table, or is it typical to reference the table?
So when we're into the discussion session, you can just use your in-text citation.
Okay.
So you can reference back to your table, but usually we don't have to so much. You will have like a study characteristics in your results in the discussion. It's not so much the referencing the table, it's just like a summary of the evidence. This was the main finding, and you're doing it more for the grouping, for the coding. Okay. let's see, 18, assessments of risk of bias for each included study. So this is your table for the each included study. So now what you're going to have is for 18, you're going to have your next table and just think about how you did your study risk before. Now you're going to have kind of the same thing. Garbus 2021, then you're going to have the different types of bias. So bias from randomization is a big one, bias from recruitment, bias from and deviation from protocol, missing data from selection data, from publication data. So all the types of bias, and then whether it was a low risk for that bias, a medium risk, or a high risk of bias. So for each study that you've got, you're going to have a bias table. So those two tables are kind of nice in that regard. And then 19. Where's my 19? Okay. For 19, we're getting into, again, for all outcomes. So now we're thinking back to our outcomes present. So whatever your outcomes were, now you're thinking for each outcome, for each study, you're going to put in summary statistics for each grouping. So if our outcome was unintended pregnancy, or our outcome was lowered blood pressure, we had to think about how we grouped those patients. So did we group them by socioeconomic status, by clinic type, like inner city, rural clinic? Did we group them by educational level? How did we group those patients? So we've got our outcomes and our groupings. Then we are going to try to do summary statistics for each grouping. And that usually ends up with a couple of figures. So you're going to have this study, and then it's summary statistics for it. So usually something like what you've decided on your risk ratio or your confidence intervals. So you're basically doing your meta-analysis summary statistics in a figure or chart-based format here.
And is this, if you do this, if you include meta-analysis in your
yes
article?
And then we start getting into the 20s, which is a lot of things. The 20s have a lot of things. So this is another big 20A through 20D. So in 20A, and I think there's, let me scroll down this page. I think that, yes, 20 had a lot of questions, results of synthesis. Okay, so 20A is a written paragraph. And this is, it's giving you an overview of your chosen studies for analysis. So let's say I did 10 randomized controlled trials that looked at comparing lisinopril as compared to hydrochlorothiazide, so an ACE inhibitor, as composed to a diuretic for blood pressure in the rural clinic setting, in the free clinic setting. So I'm using basically one old drug compared to another old drug. And these randomized controlled trials enrolled 100 patients in free clinic settings and used home blood pressure monitoring as well as clinic blood pressure monitoring. These trials, these 10 trials, were low risk of bias. All 10 trials were low risk of bias. If they weren't, then I would line them out. 4 trials were low risk of bias. 3 trials were medium risk of bias. 1 trial was higher risk of bias due to non-randomization. I would say why. Oral lisinopril and oral hydrochlorothiazide was administered in all of these. All results were pooled. So I'm going to say what was the characteristics and the risk of bias among the contributing studies. So if I'm doing a synthesis on blood pressure management, that's the characteristics and types. So when I give the synthesis, I'm saying how many studies I looked at, what was the type of study, what was the comparison in that study, what was the risk of bias in that study, and was there a major outcome in the study? Okay. In 20B, I'm putting in that summary with statistics. So when I do 20B, I'm going to say that of those studies, all of these patients, they had no major complications or they had major complications, and why. Of my 100 patients enrolled on lisinopril and hydrochlorothiazide, there were no major complications reported. Or let's say there were 20 major complications reported. Stroke was the major complication reported, and it was associated with medication non-compliance. Risk ratio 2.67, confidence interval 1.28 to 1.32, and then the p-value. And I would put those statistics in there. When you get into your 20C, you're going to start pulling in together all of your trials that you looked at. So you're among all trials that recruited patients, several recruited critically ill patients and who were not receiving oral medications, but IV medications. The relationship between patients receiving IV medications was markedly increased for those patients who were systemically ill. However, only 3 patients were in that group. All trials contributed to data according to age group and sex. And then you're going to add in your statistics for the patients that were added in for the critically ill group. So I had multiple groupings in this. I had just my patients receiving oral medications, my patients that had complications. So that would be like my coding groups, right? Oral medication group, patients that had heart attack. Now my patients that are hospitalized and receiving IV medications, because those patients aren't coming to my free clinic, my hospitalized patients. So I've got my coding groups being added in there. And then finally, I'm going to have this in 20D, results of all sensitivity analysis conducted. So in 20D, you're getting a little bit bigger in that report. Come back here, 20D. Where's my 20D? Got too many pages floating around here. You may or may not have sensitivity analysis for that, but that's going to be coming out of statisticians who are going to run sensitivity analysis for you. All right, 21. You're going to have to talk about missing analysis, missing results. Usually those are your reporting biases, and those may or may not be present. So you'll talk about any removed studies. You may have removed studies, you may not have removed studies. And then you'll get back to your certainty of evidence, which certainty of evidence, you've already done that once on certainty of evidence. So certainty of evidence comes back again. You're going to talk about your certainty of evidence coming back around, and your certainty of evidence is going to show you that it's kind of your summary statement. So compared with lisinopril, hydrochlorothiazide has a low certainty of evidence regarding effect on blood pressure medication at 1 year of treatment. This evidence was downgraded once for bias, or this evidence was not downgraded, depending on what all the reviewers decided. A summary of findings presents the same information. So I would have a table perhaps that showed that I put my 21A, my 20A, 20B, 20C, and 20D findings all together at once, that I had my randomized controlled trials together, my B together, my C together, and my D together that showed that lisinopril performed fine, except against IV medication, which is not a fair comparison of lisinopril against an IV medication. Your final part in, that's all for results. And then we get into discussion, which is 23A. This is where you're doing your general interpretation of this information. So general interpretation is going to be like a big, broad overview, because you've already gone into your heavy nitty gritty information. So how is this relevant? Why did you do this paper? So you're kind of tying it back to your initial, all the way back up in rationale, introduction and rationale. Why did I do this paper in the first place? It should be something that changes current practice or affirms current practice. So you want to talk about these findings are relevant or currently backing what is currently done. That the finding is either consistent or new and supports evidence that is out there right now. So like the example that's in here is that we need to exercise caution in interpreting these findings because it's a small number of studies. If you have a large number of studies, you don't say that.
So I just want to jump in over here. So I know that we're like over an hour. So if we want to wrap up, we can just skip.
Just barely, and we're almost done. So if you guys are good, if you need to go ahead. But we made it. I'm excited. They found, so it talks about how the findings appear to be largely in line with recent review on what works to improve outcomes in patients with alcoholism and homelessness. So there are like some interventions that can be done to help patients, and that it is overall effective. It talks about continuing like technology and education, and not finding evidence that group homes were the best things for patients overall, that an individualized approach is the best thing for a patient. Then when it gets into discussing limitations, you always want to talk about how your evidence, how your review can be improved, because people will always find what went wrong with things. So the population sizes, look at your populations. How are the studies limited? It would almost be impossible to find a study that looks at all ethnicities, all races, all ages, all sexes, all socioeconomic groups. They don't. So find what your studies were limited on. Was it small study sizes? Was it selection bias? Was it all Caucasian females? For some reason, so many studies are all done on middle-class Caucasian males or females, because apparently that's the only group out there. So look at what the studies were done on. Is it applicable to the groups that we're interested in? That's one of the most frustrating things about research is all studies tend to be done on this group of people instead of the world of people that we need to find out answers on. So there's a really interesting study out there on the effects of naltrexone combined with ketamine for alcohol abuse. And they did the study on all healthy people who don't drink alcohol. That's useful. So if we're looking at, does it work to treat alcohol abuse, but we did it on people who, and the exclusion criteria was anyone who had had alcohol in the last 2 years or had ever been diagnosed with an alcohol disorder. So that's applicable. So look at your limitations and talk about things that, was the study applicable? Was their sample applicable to the population as a whole? That's a big thing that will definitely get people. Let's talk about your limitations, and then how can this research be used moving forward? Where can we, so look at your limitations and definitely address future research based on your limitations, and what can be used on healthcare policy. Registration and protocol, if there is a talk, so if there is a protocol, usually your review protocol, that is something that's an appendix. And that is where you talk, you can have a thing that says, so registration is IRB. So we're not doing a personal thing here, so we don't have to have an IRB. So this is not an IRB study. Review protocol, you can easily list in there what you decided on ahead of time. So that would be an appendix. The protocol would be an appendix that you talk about your process for how many people ahead of time are going to review how many articles, how you're going to settle disputes, that kind of thing. There won't be an amendment to registration or protocol because we're not registering with IRB for this. Unless somebody has money that I don't know about, we would just clearly state that there is no funding for this review. And then we would note that no one has any conflict of interest. And then whatever data collection form we want to decide on ahead of time. So you decide ahead of time in your protocol whether you're going to use a spreadsheet, how data is going to be compiled between, that's all goes into your protocol. Mm-hmm. And I think I answered all the questions, and I will post them in the Google Doc.
Yes. Yeah, I believe I saw the question as well. And I guess one question that was recently added was, do we need to conduct literature search using multiple database, or do we stick to, let's say PubMed, and that's good?
I'm sorry, I missed that.
Do we need to conduct literature search using multiple database, or can we only use PubMed?
I think so. You could use, I would use at least 2 databases just to give you like the broad, and then you can start narrowing down from there.
Sounds good.
And I think Mia had a question. Okay, I see that, Mia. I'll answer you. Oops, come back here. My Zoom just disappeared. Okay, there it is. If we could hang on afterward. Mia has a question. She wants to hang on afterward.
Yeah, for sure.
Sure. So thank you all very much for your time today.
Thank you. We learned a lot, for sure. I'm going to end the recording now. And
sure.